Hello. Let us have a very brief review of acid-base imbalance. Are you familiar with this one? I'm sure you are familiar with the radial artery where you are most likely insert your needle to get the blood. But make sure that you do the Allen test first. Know the contraindication and indication of this. Be familiarized with the normal values of your ABG and then your electrolytes, including the albumin and the crea, and serum osmolality. Sources of error, you have this one from the sample, prolonged periods at room. You have the heparin that can decrease the pH if acidic heparin is used with this altered dismissal of heparin from the syringe. You have air bubbles. So just read this one because I know that by pausing this and reading the text, then you can get it more to have more knowledge retention. Causes of respiratory alkalosis, you have this central nervous system like your hyperventilation, your miscellaneous like your hyperthyroidism, drugs and toxins. For the causes of metabolic acidosis, just know increased anion gap and normal anion gap. So familiarize the column. Mostly the normal anion gap is on the caused by renal tubular acidosis. And for the increased anion gap, you have lactic acidosis, starvation, alcohol associated, and so on. For the metabolic alkalosis, these are the etiology. So just familiarize this. And the medications and chemicals that may cause acquired methemoglobinemia, though it is beyond ABG, but just to say that your O2 sat will be affected and also your pulse oximeter O2 sat will have a big difference in your ABG O2 sat. So just read O2 sat gap. Okay. You have this mnemonics. Just read this one. Pause the video. And also this one. And you have this in your books in the Harrisons. So our goal really is just to discuss a ABG and just to discuss the how to read the ABG actually. So just familiarize the delta gap ratio formula. You use this one if you have elevated anion gap. So just know this formula for an elevated anion gap. Okay? Then the adjusted anion gap if you have low albumin. So just remember that one. This serum osmolality is significant only if you're suspecting for ingestion of toxic alcohols. So you must have also the calculated serum osmolality but also the measured. So your laboratory is capable of measuring serum osmolality, and a difference of greater than 20 would more likely uh, give you a clue for toxic alcohol. This etiologies of an elevated gap acidosis, just familiarize this. And also, if not elevated, but not metabolic acidosis, but you have alteration in an ion gap, you have this pathology or etiology. Okay, especially the low anion gap because you ingested battery containing lithium or bromide ingestion and so on. So these are the disorders, and I think this is self-explanatory and better be explained by this table. Metabolic acidosis, so you increase ventilation to decrease CO2, increase pH, and so on. So just pause this video and familiarize this. So the steps algorithm for assessing acid-base status. Just we will check first the pH, check PCO2. If the PCO2 is deranged in the same direction as pH, the initially identified disorder is metabolic. If deranged in the opposite direction, the disorder is respiratory. So this is the rule. Okay, just familiarize this one and you will have your reading on the ABG. Let us have an example. Number 1, you have here 45-year-old male, so alcoholic drinker. The ABG is 7.17, no? Complaining of vomiting. So if you have this ABG, because the patient is complaining of vomiting and then maybe a reduced sensorium, so the pH is acidemia because your pH is 7.17. It is less than 7.35. Next step is PCO2. So your PCO2, high of CO2, okay? So this would explain the low pH and it might be a respiratory acidosis. So third is you check the compensation. Evaluate compensation. So you see in that table a while ago, there is a table of formula for compensation. So we grab this here. You see this respiratory acidosis. We will use the acute formula for compensation. And the calculated is 26.5. But your bicarb here is 22. So the compensation, the bicarb is lower than the expected. So since you must only have 26.5, but then um, your bicarb is lower than expected, so maybe you might also have metabolic acidosis. So you have now two primary, respiratory acidosis and metabolic acidosis. So it is mixed. Since you have metabolic acidosis, you proceed to calculate the anion gap. Okay, but if this is respiratory acidosis only, so no more step 4. Okay, the anion gap is elevated and the albumin is low, so you use the adjusted anion gap formula. You have 22. So the normal anion gap is around 8 to 12 or 14. So 22 is high. That's why if adjusted anion gap is elevated, so you calculate for delta ratio. So the delta ratio would show another etiology, maybe another disease entity. So you have here, let's go back to the table because this is very important, the delta gap. If the delta gap is revealing greater than 2, you must have a metabolic alkalosis, whatever the pathology in the step 1 to 4. So you might also have a metabolic alkalosis. If 1 to 2 only, so pure high anion gap metabolic acidosis. If 0.4 to 1, maybe you might also have a normal anion gap metabolic acidosis. And 0.4, less than 0.4, you have hyperchloremic normal anion gap metabolic acidosis. Okay? So here, you have a 3 problem. Metabolic alkalosis is the third problem after calculating the delta ratio. So your ABG would show respiratory acidosis with high anion gap, metabolic acidosis, and metabolic alkalosis. Okay. Second example is you have here a 60-year-old female, DOB and fever. But let us not discuss the presentation, just look at the ABG. Okay, so check pH, that is elevated, and alkalemia. So check PaCO2, it's lower, so maybe this is the cause of alkalemia. So this is respiratory alkalosis. Okay, check the compensation if the bicarb 17 is appropriate compensation. But here, if you calculate the respiratory alkalosis formula for compensation, using this formula, 40 minus PaCO2 divided by 10 times 2 minus 24. So you will get 25.5. So the bicarb here is lower. So meaning, you might also have a metabolic acidosis because you have a lower bicarb than expected or calculated. So calculate the anion gap because you have metabolic acidosis, so you proceed to step 4. The anion gap is 21 and you have a low albumin, so you adjust it, so the anion gap is 24. Now, because you have elevated anion gap, you proceed to step 5. You calculate for delta ratio. So if you have a metabolic acidosis with elevated anion gap, you proceed to step 5. Okay? So your step 5 would show that your delta ratio is 1.7. So it is falls within the expectation range, as you have seen that table a while ago. So just go back to that table if you don't familiar uh, familiar with the normal or the values that is being enumerated in that table. So your ABG would show respiratory alkalosis plus high anion gap metabolic acidosis. Okay? Third, you have 28-year-old male schizophrenia but unconscious. So your ABG, your CBG show lower sugar. So you must give a D50-50 here for the adult because this is 28-year-old. But then upon interpreting the ABG, your pH is 7.0. Check for PCO2 60. So this might explain the acidosis. So you might have respiratory acidosis. Compensation, that bicarb is 12. Is it appropriately compensated? Using the respiratory acidosis formula for compensation, I think you might have same result, 25.5. So the bicarbonate is lower than expected. So metabolic acidosis. So aside from respiratory acidosis, you have metabolic acidosis. Since metabolic acidosis, you proceed to step 4, an ion gap, and the anion gap is elevated. Then you proceed to step 5. The step 5 would show that the delta ratio is 1.7. So there is no third um, primary derangement of the acid base because the delta ratio would show 1.7 only, and you might have a pure high anion gap metabolic acidosis, so might have pure. So the ABG would show respiratory acidosis and high anion gap metabolic acidosis. For the fourth example, you have your 34-year-old male. So your pH acidemia. So meaning the PCO2 will not explain your acidemia. So you go to HCO3 and your HCO3 would explain your acidemia. So the process is more on metabolic acidosis because your CO2 would show respiratory alkalosis but the pH is acidemia. So the process is metabolic acidosis. Evaluate compensation if 14 is really appropriate compensation for the metabolic acidosis. So using your Winter's formula, 1.5 times bicarb plus 8, it showed that you have 8.75. So 8.75 is no, the 8 the anion gap is 10 meg. I mean the the PeCO2 is around 29 and the calculated is 29, but your actual PeCO2 in the ABG is 28. Okay, so meaning it is appropriately compensated because it's closer. 28 and 29, it's near than expected, so appropriate compensation. But then you proceed to step 4 because it is metabolic acidosis. But your anion gap is normal, around 8 to 12. Okay? So no more step 5. So your ABG is normal gap, metabolic acidosis. And these are the reference. Thank you.